Hi, my name is Shayan. I'm an intensivist, and today I'm going to talk about fluid therapy in the critically ill. This is a very vast topic, and this presentation doesn't intend to talk in detail about individual clinical conditions or individualized fluid therapy. Rather, this will give you a vast or a broad overview about the physiological principles and clinical implications of fluid therapy in a day to day clinical practice. When we talk about fluid therapy, we should answer these four questions, that is, why or when to give fluids, what fluid should we choose among the numerous options, how much fluid should we give, and what should be the monitoring that we'll institute while we give fluids to our patients. If we look closely, we shall realize that these are the four questions which are pertinent to any drug therapy in our patients. And in today's world, in today's clinical practice, we consider fluids as drugs and we do not take fluids very casually. If we look at human history, we shall see that human beings can live for long even without any access to fluids. The world record is 18 days, but on an average, a human being can live up to a week without any access to fluids. Then the question is, if human beings actually can live without fluids for so long, why do our patients need fluid? Why do these patients get decompensated in our hospital if we do not give fluid in time to these patients? For that, we need to understand few basic physiological principles. We must understand that the fluid or the total body water in our body is distributed among three compartments. The majority of which lies in the intracellular fluid compartment, then there is interstitial fluid, and then there is plasma. In an average human adult, if he's 70 kilos weight, then the total body water will be somewhere around 60% of the total body weight, and that will be around 42 liters of total body water. And majority of this total body water will be there in the intracellular fluid compartment. Um, and then there will be interstitial fluid, which will be around 10 to 11 liters, and the smallest compartment will be plasma, which is around just 3 to 3.5 liters. Though plasma is the smallest of all compartments, it is peculiar that the intake that we have, or the intake that we give to our patients in the form of intravenous fluid, will initially go to plasma and then distribute into the other compartments. On the other hand, if there is a loss, the loss primarily happens from the plasma compartment. So plasma, even though it is the smallest compartment, it is the most important of all the compartments when we talk about fluid therapy. We must also talk about this, that the junction between the interstitial fluid and the intracellular fluid is tightly regulated by the cell membrane or the plasma membrane. This is the very basis of life. Even the unicellular organisms try to maintain a constant cell volume, and our multicellular organisms are no different. And in most clinical situations, unless there is a very rapid and high change in osmolarity, this compartment is tightly regulated and there is not much fluid which is exchanged between these two compartments, that is the interstitial fluid compartment and the intracellular fluid compartment. On the other hand, the junction between the plasma and the interstitial fluid is actually very leaky, which is bound by the capillary membrane, and it becomes even more leaky in certain clinical conditions that we are going to talk about subsequently. Now let us talk about how or what happens when there is no access to fluid, or there is fluid loss or dehydration. What are the compensatory mechanisms that help human beings survive the loss of fluid or no access to fluids? The first thing that happens immediately is something called capillary fluid shift mechanism, where the hydrostatic pressure in the capillary end decreases when there is decreased fluid in your intravascular compartment, and this leads to decreased transmigration of fluids from your capillaries into the interstitial fluid. Then there is ADH secretions from your posterior pituitary, which tries to restore the plasma volume by decreasing diuresis or decreasing free water clearance. Then there is increase in renin, angiotensin, and aldosterone secretion, which will try to restore your blood pressure and try to maintain the glomerular filtration rate. Then there is decreased secretion of atrial natriuretic peptides, which will decrease natriuresis and try to restore the plasma volume. We must realize that all these four compensatory mechanisms are trying to restore one compartment of our body, that is the plasma volume. Uh, and we must also realize that these four mechanisms will take some time to act. The instantaneous mechanism is the capillary fluid shift mechanisms, but other mechanisms take time to act. And in situations where fluid loss is very rapid, these mechanisms will fail to restore the normal homeostasis of our body, or in other words, the compensatory mechanisms won't suffice to maintain a normal physiological state when there is a rapid fluid loss. So let us see what happens in rapid fluid loss. So suppose this is a normal individual with the three compartments of its body, and suppose there is a sudden loss of the intravascular fluid. This condition is known as hypovolemic shock. Of course, the compensatory mechanisms will try to play some role here to restore the intravascular compartment, but this will fail if the loss is very rapid. In certain other clinical situations, the total body water or the total body fluid remains constant, but there is a rapid redistribution of fluids from the intravascular fluid to the interstitial fluid. And this happens very rapidly, and there is rapid shrinkage of the intravascular fluid compartment. And these conditions are known as distributive shock. The commonest of all is septic shock. In both these conditions, there is a rapid loss of the intravascular compartment, which will lead to rapid loss of preload to our heart, and in other words, this will decrease the cardiac output very rapidly. This is also known as shock, and in shock states, when there is decreased cardiac output, it will fail to perfuse our organs adequately, which will lead to organ dysfunction. So these are the situations, that is when there is rapid shrinkage of the intravascular fluid compartment. These are the situations where we need to restore the intravascular fluid compartment very fast, and this is the basis of giving resuscitation fluid to our patients. In other situations where there is no shock or the patient is much more stable, generally our water input will match our water output. So let us look at what are the inputs of water in our body. Most of the input of water daily comes from our nutritional supplements or nutrition that we take. There is water content in our foods. There is water content there is water that we take, and then there is something known as metabolic water. What is metabolic water? As we can understand from the name, it is the water which is produced in the end of metabolic reactions. If you look at Krebs cycle, the formula of Krebs cycle, there is some 6H2O component at the end of the reaction. So 6H2O is the metabolic water produced at the end of Krebs cycle, and likewise there are other metabolic reactions happening in your body continuously, which is also generating water. So even if you do not have any access to external fluid supply, your body will generate metabolic water, which will be somewhere around 200 to 300 ml on a daily basis. This will be around 10% of total daily fluid requirement. In animals like camels, migratory birds, this metabolic water actually gives much more fluids to them, but unfortunately for human beings, it is just around 10% of daily fluid requirement. On the other hand, let us look at what are the outputs. The majority of the output is urine, and also we lose water along with our sweat, our respiration, along with our feces, and together we call this as insensible water loss. In most of the situations, our fluid intake and metabolic water matches our urine output and insensible loss, or in other words, our intake and output are matched. In critically ill patients, the intake comprises of the nutritional fluid, the drug dilutions, and along with that the metabolic water, which will comprise the total intake. And in most of the situations, this will be matching with our urine output and insensible loss. If it doesn't, then we need to give something known as maintenance fluid to our patients, where maintenance fluid will be calculated as the amount of fluid which is the subtraction or which is the difference between the output and the input of fluids in our body. In other words, if our urine and insensible loss is more than our metabolic water and nutrition and drugs, then the rest of the amount should be given as maintenance fluids. We would not require to give maintenance fluids in most of the situations, since our metabolic water and nutrition and drugs will be adequate to match our daily urine output and insensible loss. So now that we have talked about the physiological basis of most of this physiological basis of fluid therapy, we should now be ready to answer the first question, that is why to give fluids or when to give fluids. So now we know that resuscitation fluid is given in shock states to achieve a minimum preload, so that we maintain a minimum cardiac output, so that our organ perfusion is not hampered. And for obvious reasons, since we're trying to restore the intravascular fluid compartment, all our resuscitation fluids are ideal if they stay in the intravascular compartment and if they do not move out of the intravascular compartment. On the other hand, for our maintenance fluids, we give them in stable patients just to counterbalance the daily loss. And if our total intake with our nutrition and our drug dilutions and our metabolic water, if it matches our urine output and insensible loss, then we do not need to give any further maintenance fluid to our patients. Now let us look at what happens when we try to resuscitate our patients who are in shock. So suppose this is a normal patient with the normal three different components of fluids in our body, and suppose there is a rapid loss of the intravascular fluid, and immediately the compensatory mechanisms will try to act and try to restore some amount of intravascular fluid or some amount of intravascular volume by the compensatory mechanisms. But since it is happening very rapidly, it will fail to maintain or bring this intravascular fluid volume to normal, and so we need to give fluids to these patients, and this is where we start resuscitating our patients. And suppose this is the amount of fluid to bring back the fluid volume to normal. If we give this amount of fluid to our patients, it will go into the intravascular compartment first, and this is known as intravascular volume expansion. This will not stop here, of course, because some amount of fluid will pass into the interstitial fluid compartment, and in the end we shall have intravascular fluid compartment which is restored, interstitial fluid compartment which is restored, and throughout this process the intracellular fluid compartment has maintained its tight integrity. So in the end of resuscitation, we have reached back to the normal state. Had this been the situation in our clinical practice, it would have been ideal. But unfortunately, this doesn't happen because our capillaries are still leaky, and now some amount of intravascular fluid will again move into the interstitial fluid compartment, contracting our intravascular fluid once again, and again the cardiac output falls. And hence, even if we have given fluids to our patients, we are not being able to maintain the intravascular fluid volume. So what we do in reality, when we start resuscitating our patients, we give more fluids to these patients so that we restore the intravascular fluid volume. So the fluid given in practice is much more than the fluid which is needed by a calculative basis. So when we give this amount of fluid, finally we shall be restoring the intravascular fluid. If we look at number 1 and number 6, we shall see that at the end of our fluid therapy, we have restored the intravascular fluid. The intracellular fluid is constant throughout, but then the interstitial fluid has increased, a total body water has increased, and all this water has accumulated in the interstitial fluid compartment. Why am I talking about this? Why is this so important? We shall come to this in a bit. But for now, we shall talk about one thing, that this transcompartmental migration of fluids from the intravascular compartment to the interstitial compartment is maximum with hypotonic crystalloids and least with hypertonic crystalloids and colloids. So for all practical purposes, hypotonic crystalloids like 5% dextrose are not given as resuscitation fluids because they will not stay in the intravascular compartment, they will transmigrate. So why are we so concerned about causing a high interstitial fluid load at the end of fluid therapy? Because this gives rise to something called interstitial edema in all the organs. All organs have interstitium, and when there is interstitial edema, there is a decrease in diffusion of nutrients through the interstitium to our tissues, and the tissue perfusion is hampered, and our tissue and our organ dysfunction starts. For example, if there is interstitial edema in your lungs, it is nothing else other than pulmonary edema or interstitial pulmonary edema. This will lead to decreased diffusion capacity in your lungs, and this will lead to hypoxia. Similarly, interstitial edema in your gut will decrease gut function. Interstitial edema in other organs will decrease the organ function. And many studies have proven now that this giving interstitial fluids to patients, increasing the interstitial fluid or causing interstitial edema at the end of our fluid therapy will lead to worse outcomes and even increase in mortality. So for all practical purposes, when we are giving resuscitation fluid, we should be very cautious not to give excess fluid so that it doesn't cause interstitial edema. So now that we have understood the physiological basis of these things, we are now exploring the next topic, which is what fluid to give and how much fluid should we give. So if we talk about what fluid should we give, we should choose between crystalloids and colloids, and if we're choosing crystalloids, then we have to also talk about what crystalloid should we choose. So from the physiological principles that we have already discussed, it is intuitive that colloids are probably the better fluids of choice during resuscitation, because colloids are supposed to stay in the intravascular compartment. But does that happen in reality? let us look at the studies that have tried to find out the comparative outcome between the crystalloids and colloid therapy during resuscitation of patients. And most of the studies have shown that either there is no difference between these two, or there is increased mortality or harm with colloids. So this is surprising because, from our physiological idea, we think that colloids will remain more in the intravascular compartment and it should be the better resuscitation fluid. But why isn't this happening in reality? It is because colloids not just increase intravascular fluid or increase restore the intravascular compartment, but it also has its own colligative and biochemical properties. And many of these colloids also cause acute kidney injury. Many of these colloids directly cause coagulopathy, and all these adverse outcomes will lead to poor eventual outcome and increased mortality. The question remains that why isn't apart from this adverse effect, why is there no difference between colloids and crystalloids? Because colloids are supposed to ideally restore the intravascular fluid compartment better than crystalloids. There should be some volume sparing effect of colloids, but why doesn't that happen in reality? For that, we need to understand the revised Stirling model, which says that in conditions where our glycocalyx is damaged, which is most of the clinical conditions that we are discussing here, in conditions where glycocalyx is damaged, even the colloids will transmigrate out of the damaged capillaries, and it will accumulate in the subglycocalyx layer, and that will lead to increased interstitial edema even with colloids. So finally, when we give colloids thinking that it will stay in the intravascular compartment, this doesn't happen in reality. Some amount of colloid also goes into the interstitial fluid, and hence the advantage that we think that colloids will be having over crystalloids, that is offset. And in reality, the volume sparing colloids effect of colloids is just 1:1.4 with crystalloids compared to crystalloids, and not 1:3 that we used to think in the past. In the past, people thought that if we are giving 1 liter of colloid to restore intravascular volume, to restore the same amount, we must give around 3 times the crystalloid volume. This is not the reality. In reality, 1 liter of colloid is just around 1.4 liter of crystalloids. And thus, the volume sparing effect of colloid is much less than we used to think. And this is coming at a cost of increasing the adverse effect and increasing mortality. And of course, we are not ready to accept anything that increases adverse effects and mortality. And hence, in between the colloids and crystalloids, we shall always choose crystalloids as a resuscitation fluids of choice. Now, we should also talk about one topic, which is albumin, which is one of the colloids. There is a lot of discussion about whether albumin has the capacity to restore the damaged glycocalyx or not. Many preclinical studies or experimental studies have shown that albumin releases sphingosine 1 phosphate from cell membranes of blood cells, and this sphingosine 1 phosphate is something that helps in restoring the damaged glycocalyx. In the subgroup analysis of Albios trial, of course, there was benefit with albumin when given in the subgroup of sepsis patients where there is damaged glycocalyx. This gives us an important area to introspect and gives us opportunity for further clinical trials to look for evidence of albumin restoring glycocalyx in damaged conditions. But for now, in absence of major clinical trials, we shall just keep this as a future promise, and we shall not conclude anything about albumin at this point of time. And in a nutshell, we are choosing crystalloids over any other colloid while we choose our resuscitation fluids. Now that we have chosen crystalloids over any other colloids, let us talk about whether to choose normal saline or any other crystalloid while we give fluid to our patients. Oh, so why this question? Why this debate between NS and other crystalloids? That is because normal saline is the cheapest of all crystalloids. It is easily available, and also NS is slightly hyperosmolar compared to plasma. And from our physiological discussion, we believe that anything which is hyperosmolar compared to plasma probably has a better volume expanding effect than the other type of crystalloids. But what is the problem with NS then? The problem is NS contains a very high amount of chloride. It is 154 millimole per liter, which is much more than that of plasma. And this high amount of chloride load to the kidney causes something called chloride-induced acute kidney injury. So, high volume resuscitation with normal saline is supposed to cause chloride-induced acute kidney injury. On the other hand, the strong ion deficit in normal saline is zero, that is sodium minus chloride. Both are 154 milliequivalent per liter in normal saline, and hence the strong ion deficit is zero. And anything which has a strong ion deficit of zero is an acidic substance, or in other words, if we give a large amount of normal saline to our patients, it will shift the plasma strong ion deficit from a normal value of 40 towards zero, and anything which is less than 40 will drag the plasma pH towards acidotic range. This is the Stewart concept of acid-base disorders, and from its concept we know that high volume sodium chloride or high volume normal saline is going to cause metabolic acidosis. So hence sodium chloride, though it is cheap, it is easily available, it has got two problems, that is, it causes acute kidney injury and it causes a normal anion gap metabolic acidosis. Then what is the advantage of balanced salt solutions? So these balanced salt solutions have two major advantages. One, it has got lower chloride. The chloride content is much lower than that of sodium chloride or normal saline, and this lower chloride content doesn't lead to acute kidney injury, at least from our physiological understanding. Also, these balanced salt solutions are nothing but buffered salt solutions. So what is the meaning of buffered salt solution? In other words, they contain buffers or source of bicarbonate. What is this buffer? Example, for Ringal lactate, the buffer is actually the sodium lactate that is there in the Ringal lactate. For plasmalite, it is the sodium acetate that is there in the plasmalite. So what are these buffers doing when we give this to our patients? So suppose we give Ringal lactate to our patient, the sodium lactate is taken up by the liver, and this lactate is oxidized to generate bicarbonate in 1:1 ratio. So rather than causing lactic acidosis, the sodium lactate in Ringal lactate is actually a source of bicarbonate which will buffer acidosis. I'm telling this because many people think that Ringal lactate will worsen acidosis, and they're afraid to give Ringal lactate in patients who have acidosis. This doesn't have any physiological basis because the Ringal lactate that we are giving contains sodium lactate and not hydrogen lactate. There is not additional hydrogen or H plus load to your patients when you give Ringal lactate, and it is not causing acidosis, rather it is helping in buffering the acidosis, being a source of bicarbonate. Is it proven in clinical trials? Yeah, it is proven. And this study was done in end-stage renal disease patients who are undergoing kidney transplant. Mind you that these are the patients who have the highest risk of metabolic acidosis and hyperkalemia. These are the end-stage renal disease patients. But even in these patients, Ringal lactate was associated with less hyperkalemia and less acidosis when compared to normal saline. This is surprising because normal saline doesn't contain potassium, but yet it worsens hyperkalemia. And this happens only because sodium chloride, when given in large volume, causes metabolic acidosis, and this acidosis is the cause of hyperkalemia or worsening of hyperkalemia with sodium chloride. In other words, lactate or Ringal lactate is not the problem. Sodium chloride given in high volume can actually cause problem by causing metabolic acidosis and hyperkalemia. In more stable patients of chronic kidney disease, even in these patients, it was proven that Ringal lactate does not cause hyperkalemia, even though it contains potassium, while sodium chloride can actually worsen hyperkalemia, even if it does not contain potassium. And this trial was published in 2021. This is a landmark trial. This is COPE-DK trial, where it was shown that even in diabetic ketoacidosis patients, where for decades normal saline was said to be the fluid of choice, even in those patients the buffered salt solutions are resolving acidosis faster when compared to normal saline. And now we understand that there is a physiological basis to it, because normal saline itself will cause a normal anion gap metabolic acidosis. So even in DK patients, we should be cautious about giving high volumes of sodium chloride or normal saline, now that we understand physiology better. So all these trials had successively proven that probably buffered salt solutions are better than normal saline in many clinical situations. But then there are many large trials which have tried to compare resuscitation with normal saline versus balanced salt solutions and tried to see if there is any difference in outcome. So these initial two trials, the SMART trial and the SALTED trial, they suggested that probably high volume resuscitation or initial resuscitation with normal saline will worsen acute kidney injury in critically ill patients. But subsequently, there are three different trials: the SPLIT trial, the BASICS trial, and the PLUS trial. They have proven that there was no difference between the two therapy, that is between normal saline and balanced salt solutions, when given in critically ill patients as a resuscitation fluid. Then what to do? What do we do when we have different evidences from different randomized controlled trials on the same topic? Yes, we go ahead with the meta-analysis. So let us look at what the meta-analysis say. Surprisingly, there are three meta-analyses all published in the same year on this topic. The first one was by Hammond et al., which showed that there was no difference in resuscitation between normal saline and balanced crystalloids. Dong et al. Went further deeper and said that no, balanced salt solution actually reduces mortality in non-TBI patients when compared to normal saline, but it increases mortality in TBI patients, and hence there is no overall difference. And finally, Beran et al. Had seen this meta-analysis only for sepsis patients, and they concluded that balanced salt solution improves mortality in sepsis. But this last meta-analysis also has to be taken with a pinch of salt, because they included both randomized controlled trials and observational studies, and this finding was only seen when both RCT and observational trials were included, and only if only the randomized controlled trials are included in the meta-analysis, there was no difference. Looking at all the evidences, finally, the balance is somewhat skewed towards the balanced salt solutions if we talk about the resuscitation fluids. And for now, we choose normal saline over choose balanced salt solutions over normal saline from our physiological understanding of fluid therapy. So, do we stop giving sodium chloride, or do we stop giving normal saline? No, we do not stop, because it is the choice of fluid in certain clinical conditions like traumatic brain injury, in patients of hyponatremia, and in patients of upper GI loss. In the latter, there is a chloride responsive metabolic alkalosis, and normal saline is, of course, the fluid of choice. But in majority of the situations, we choose crystalloids and balanced salt solutions among the crystalloids. And we must realize that among the crystalloids, among the balanced salt solutions, Plasma-Lyte and RL are equally effective, and at least RL is the cheaper alternative to any other costly balanced salt solution. We must also realize that and hammer into our heads that RL does not cause hyperlactatemia in patients of normal liver function. But what about hemorrhagic shock? Of course, in hemorrhagic shock, we start resuscitating our patients with fluids because we try to maintain the initial resuscitation phase. We try to maintain the preload and minimum cardiac output. But we must also understand that in hemorrhagic shock, it is not just the volume which is lost. We are also losing coagulation factors, which we are also losing the RBCs, and hence the oxygen carrying capacity of blood is also decreasing, and there is coagulopathy because of loss of coagulation factors, and hence the ideal fluid of resuscitation for hemorrhagic shock is actually nothing other than blood and blood products. Of course, we start resuscitating with fluids, but we try to limit the amount of fluid, because it has been shown if we give too much volume of fluids in hemorrhagic shock, it will worsen coagulopathy. And we must be reminded that in the recent recent ATLS update, they have recommended that we limit our initial fluid volume while we are resuscitating hemorrhagic shock patients. Now that we have talked about what fluid to choose, and we have chosen crystalloids in most of the situations, let us talk about how much fluid should we give to our patients. And when we talk about this, we have already discussed that our maintenance fluids should cover our daily needs, and generally our nutritional fluid intake, our metabolic water generally suffices, and if it doesn't, then only we give maintenance fluids to our patients. This is more a discussion of nutrition, and I'm not going into details of this topic. Rather, we should concentrate more on the resuscitation fluid. So, how much resuscitation fluid should we give? The simplest answer is, as long as the patient can increase the cardiac output with fluids, we should keep we should keep giving resuscitation fluids to our patients unless we are causing fluid overload with that. On the left, you can see the Frank-Starling curves, and of course now we understand that different patients will belong to different part of the Frank-Starling curve depending on the cardiac compliance, and not all patients who are in fluid deficit will be equally fluid responsive. So when we are talking about fluid responsiveness, we are actually talking about cardiac output response of the cardiac output with our fluids, or in other words, when you are giving fluids, our cardiac output is increasing, and this is what we check in fluid responsiveness, that whether we are being able to increase our cardiac output when we are giving resuscitation fluids to our patient or not. If we do not have cardiac output, if we do not measure cardiac output, then there are surrogates to measure this fluid responsiveness. So there are innumerable tests to look for fluid responsiveness in different clinical conditions, depending on whether the patient is spontaneously breathing or whether the patient is mechanically ventilated or not. But what is important to know is that this passive leg rest test and the mini fluid challenge mostly work under almost all circumstances. In most of the situations, the most practical that is supposed to be done is a passive leg rest test, and for that we need very precise cardiac output monitor which is continuous, and an increase in cardiac output of more than 10% during a passive leg rest test will tell that the patient is fluid responsive, and we give more fluids to this patient. If we do not have cardiac output monitor, we can also look at the pulse pressure variation or the stroke volume variation. If we do not have that also, then also we can look for fluid responsiveness by the perfusion index on our pulse oximetry. And there are people who have also studied whether EtCO2 rise and capillary refill time fall during a passive leg rest test can be done to check for fluid responsiveness. They have concluded that yeah, they can be done, but in clinical practice, it is difficult to replicate. People have also done studies to look at differences in outcome between the conservative and liberal fluid management in critically ill patients, and most of the studies have favored the restrictive strategy. And it has also been shown that high volume initial resuscitation in the form of bolus of 20 to 30 ml per kg of fluids can actually worsen patient prognosis. That FEAST trial in Africa, which was done in children, febrile children, it had showed that initial 20 ml per kg of fluid, whatever fluid we have given, initial 20 ml per kg bolus had actually worsened prognosis and worsened mortality in patients rather than improving that. So we must be very cautious when we are giving initial high volume of bolus fluids to our patients. When the sepsis guidelines were first formulated, there was a concept of early goal-directed therapy or early goal-directed fluid therapy, where a very high initial 20 to 30 ml per kg of fluid was recommended. But subsequently, there are three major trials, the PROCESS, ARISE, and PROMISE trials, which have been done in 3 different continents. They have shown that this early goal-directed therapy is actually an inferior way to give fluids in patients of septic shock, and now we consider that it is an inferior choice when we talk about fluid therapy. Finally, in 2023, the CLOVERS trial was published, which increased our confusion regarding fluids, because this trial showed that initial resuscitation strategy between a liberal and restrictive strategy didn't lead to any difference in outcome in 90 days. This trial actually is a very important trial, but it also has to be remembered that this trial has got few weaknesses. It was unblinded trial. There might have been some selection bias in this trial. There might be some other form of bias, because majority of not majority, a significant part of this fluid therapy was left to individual clinician choice, which is of course a source of bias. And the most important part is that it doesn't talk about the fluid management in the later part of ICU stay. Though they have seen the 90-day mortality as their primary outcome, the later part of fluid management was not discussed in clear detail, and this is an enigmatic part of this trial. And why am I telling this? Because the late part of the fluid management is also as important as the initial fluid management in the critical ill patients. This was proven in 2009 by Murphy et al., who showed that if we fail to give initial adequate amount of fluids to our patients, which shall cause more harm than giving more fluids to our patients in the initial part. It is not a problem if we give aggressive fluids in the initial period, but if we follow it subsequently with a late conservative fluid strategy, it will carry the best prognosis. So this gave rise to this concept of Rose model of fluid therapy, and that is resuscitation followed by optimization followed by stabilization and followed by evacuation. In the resuscitation phase, in the initial part of the critical illness, we give early aggressive fluid to our patients, and then once we achieve some form of clinical stability, we go for conservative fluid management, and in the end we can actually remove extra amount of fluids in the form of diuresis or ultrafiltration. We call that late goal directed fluid removal in the later phase of fluid management. And all these four phases of fluid management are actually important while we talk about the intravenous fluid therapy of our patients. So, in the nutshell, if we talk about how much of resuscitation fluid should be given, we must say that, of course, we should initiate fluids if there is obvious hypovolemia. Suppose a patient is in shock and you can see the patient bleeding, or there is a history of trauma, you can see that there is hemorrhage. Of course, we shall start resuscitating these patients in obvious hypovolemia. We do not wait for fancy gadgets to initiate fluid therapy in these patients. It is better to restrict the initial fluid bolus to 10 ml per kg rather than higher volumes like 20 to 30 ml per kg. And few authors even suggest that we give fluids in even smaller aliquots and look for fluid responsiveness and check whether giving this amount of fluid is actually beneficial to our patients or not. And the idea is to give guided fluid therapy, which raises the cardiac output, which is the primary goal of resuscitation fluid, and which does not cause any fluid overload in our patients. And in the end, once a patient is stable, we should remove this extra amount of fluid. So if we talk about duration of fluid, of course, by now we have realized that we do not give additional fluids to our patients if it is not needed. So we stop IV fluid therapy when it is not needed, and when daily water intake can be taken by our patients in the form of enterally, or when they are being able to take orally, we stop IV fluid at that point of time. When we talk about monitoring, of course, there are innumerable monitors which are available which can guide our fluid therapy. What is important is to know what is the minimum and what is the optimum monitoring in each stage of fluid therapy. If you have all the gadgets, you are free to use all the gadgets, but then it is not needed. Suppose in the resuscitation phase, where the primary goal is to salvage our patients, that is to maintain a minimum cardiac output, we really do not need pulse pressure variation or cardiac output monitors to initiate fluid therapy in these patients. Of course, it is good if you have and if you can put them in put them in your patient very fast. But then, even if you do not have that, that's not a problem, because initial resuscitation can be guided by capillary refill time and lactate. This was very well shown in the Andromeda shock trial, which showed that initial resuscitation fluid guided by the capillary refill time is at least as good as guiding fluid therapy with lactates. In the optimization phase, when we are looking for organ rescue, this is the ideal time to go ahead with this cardiac output monitors and fluid responsiveness check every time we are giving fluids to our patients. And also, it is important to look at the global perfusion markers like lactates, base deficit, and nowadays we are also talking about veno-arterial CO2 gap. These are the monitoring which we can apply or implement during the next phase of fluid therapy. Can continue that in the stabilization phase. It is very good if we have transpulmonary thermodilution in the stabilization phase, because this will give us extravascular lung water and will indicate if we are giving too much fluids and causing interstitial edema in our patients, which is our primary concern regarding fluid therapy. We can also look at the venous excess ultrasound, or VEXUS, to look for organ congestion. And if we have congestion in our organs, we decide to remove this extra amount of fluid in the evacuation phase. And finally, in the evacuation phase, when you are removing extra amount of fluid, we should start probably removing the invasive monitors, because now our patient is stable and it is time to de-escalate our therapy. It is not just the fluid therapy, we de-escalate therapy and we plan the patient for further management in the ICU. Nowadays, we are also talking about looking at the microcirculation, that is at the level of capillaries and arterioles, to see if there is coherence between the macrohemodynamics and microhemodynamics. We look at microcirculation with side stream dark field microscopy, which is a promising tool, but the utility of it in large scale clinical studies is yet to be proven. Now, finally, we have covered all the important questions that we had intended to answer in this presentation. That is, why to give fluids or when to give fluids, what fluid to choose, how much fluid should we give, and what should be the monitoring that we should apply during fluid therapy. And finally, we should be reminded of all these points that fluids are drugs. Not every patient with a volume deficit will need IV fluid. Resuscitation and maintenance fluid have different roles during fluid therapy. Crystalloids are the first choice of fluid in most of the situations. And whatever fluid we give intravenously, some amount will always go to the interstitial fluid compartment, and hence we should be very cautious while giving fluids to our patients. And it is important to stop fluid on time, and if possible to remove the extra fluid on time. This concludes this presentation on fluid therapy. I hope this answers most of the questions which we are facing on day-to-day practice in our fluid when we decide to give fluids to our patients. Thank you. If you have any questions, you can comment. Thank you so much.